Almost every patient over 60 in the cases I have reviewed over the last 15 years arrived believing the same thing. They believed their knee was hurting because of arthritis. Some had been told this by a friend. Some had been told it by a previous doctor. Some had simply concluded it themselves, because arthritis is what people over 60 are supposed to have. In case after case, when we actually looked at what was driving the pain, arthritis was either a small part of the story or no part of the story at all. The pain was coming from somewhere else, and that somewhere else was almost always fixable in a way that arthritis is not. After 30 years of clinical observation, I am going to tell you the 5 most common non-arthritis causes of knee pain over 60, and I am going to show you what to do about each one. A quick note before we go further. This is educational content, not medical advice. Some of you watching do have arthritis that is the dominant driver of your knee pain, and for you the picture is different and worth discussing with your physical therapist or orthopedic team. Do not use this video as a substitute for a hands-on assessment. Dr. James Whitaker is a composite educational character built from 30 years of represented physical therapy experience. If you have had recent surgery, severe osteoporosis, or significant balance impairment, please work with a hands-on clinician before changing anything about your treatment plan. Now, the contrarian frame. For decades, the standard answer for knee pain in adults over 60 was, you have wear and tear, you have arthritis, take an anti-inflammatory, rest, and prepare for surgery in the future. The research has caught up, and movement is the new standard. The reason that frame is shifting is that imaging studies have repeatedly shown something inconvenient. When researchers scan the knees of asymptomatic adults over 60, those who have no knee pain at all, they find arthritic changes in well over half of them. A 2017 paper in BMJ Open, looking at over 1,000 asymptomatic older adults, found radiographic knee osteoarthritis in around 60%. 60% had the picture of arthritis on the scan, and 0 of them had pain. That single finding tells us that arthritis on imaging and pain in real life are not the same thing. The pain has to be coming from somewhere else. Cause number 1 is a weak gluteus medius. The gluteus medius is the muscle on the side of the hip, the one that fires when you stand on one leg. Its job is to hold the pelvis level over the standing leg. When the gluteus medius is weak, the pelvis tilts. The tilt forces the knee to track inward, and the band of fibrous tissue running down the outside of the thigh, called the iliotibial band, gets pulled into a position where it scrapes against the outside of the knee with every step. That is the picture documented in case after case I have seen for outer or general knee pain. The knee was the messenger, the hip was the culprit. A 2017 paper in the Journal of Orthopedic and Sports Physical Therapy, following 160 older adults with anterior knee pain, found that 12 weeks of hip strengthening exercises produced significantly greater pain reduction than knee-focused exercises alone. The single most useful exercise for this is the side-lying leg lift. Lie on your side, bottom leg slightly bent for stability, top leg straight. Lift the top leg up about a foot. Hold for 2 seconds. Lower. 10 on each side, twice a day. The first week you will not feel much. By the 3rd week, the muscle wakes up. By week 8, the knee on that side is often a different knee. Cause number 2 is short hip flexors. The hip flexors are the muscles on the front of the hip, the ones that pull the thigh up toward the chest. In adults over 60 who spend hours sitting every day, and that is most of us, the hip flexors shorten and stiffen over time. A short hip flexor pulls the pelvis into an anterior tilt, which sways the lower back forward and changes the angle of the femur, which is the long thigh bone, as it meets the knee joint. The kneecap, which is meant to glide smoothly in a groove on the femur, no longer tracks where it should. The result is the kind of front of knee pain that lots of people call patellar tracking pain, and lots of doctors briefly call patellofemoral pain syndrome. Let me pause here for a moment. I want to make a point that runs through everything I am about to tell you. The knee almost never invents its own problems. The knee responds to what is happening above it and below it. If the hip is tight, the knee pays. If the ankle is stiff, the knee pays. If the foot is collapsed, the knee pays. The knee is in the middle of a chain, and the middle of the chain takes the abuse from everything else. The job of a good rehabilitation plan is not to fix the knee. The job is to find the upstream and downstream culprits and unload the knee. The fix for short hip flexors is a gentle daily hip flexor stretch. The kneeling lunge stretch is the classic. Kneel on one knee, the other foot forward. Push your hip gently forward until you feel a stretch on the front of the down leg hip. Hold for 30 seconds. Do this twice a day. If you cannot get to the floor safely, the standing version against a wall or a counter works as well. 6 weeks of this stretch combined with the side-lying leg lift will change a great many 60-plus knees that have been blamed on arthritis for years. A small additional point about the hip flexors. The deepest of them, called the iliopsoas, runs from inside the front of the spine down through the pelvis to the inner thigh. When the iliopsoas is short, it pulls the lower back forward into the sway back position so commonly seen in older adults, and the entire posture changes the way the knee tracks during every step. Working on the hip flexor is therefore also working on the lower back, the abdomen, and the knee at the same time. Few exercises in the lower body offer that much downstream payoff for so little time invested. 90 seconds per side, twice a day, 6 weeks. Cause number 3 is quadriceps imbalance, specifically wasting of a small muscle on the inside of the quadriceps called the vastus medialis obliquus, or VMO. The VMO is the muscle just above and inside the kneecap, the one that bulges visibly when a strong-legged person flexes their thigh. It is the muscle most responsible for keeping the kneecap pulled toward the inside of its groove during knee extension. In adults over 60, the VMO is often the first quadriceps muscle to atrophy, especially after a period of inactivity, illness, or any injury that put weight off the leg for a few weeks. Once the VMO weakens, the kneecap is pulled outward by the larger lateral quadriceps muscle, and the cartilage on the outside of the kneecap groove starts taking load it was never meant to take. That is one of the most common drivers of front of knee pain in the cases I have reviewed, and almost none of those patients had been told about it. The fix is the terminal knee extension. Sit in a chair with a small rolled towel under one knee. Slowly straighten that leg until the knee is fully extended. Hold for 3 seconds. Slowly lower. 10 repetitions on each side, twice a day. The VMO is recruited most strongly in the last 15 degrees of knee extension, which is what this exercise targets. Case after case I have seen documented for front of knee pain saw substantial relief from this single movement within 4 to 6 weeks. Cause number 4 is ankle stiffness referring upward. The ankle is the foundation of the leg. If the ankle does not bend forward freely, called dorsiflexion, the knee has to compensate every time you step, every time you squat, and every time you go downstairs. Limited ankle dorsiflexion is shockingly common in adults over 60, partly because of a lifetime of shoes with elevated heels, partly because of habit, and partly because of past ankle injuries that never quite resolved. A 2019 paper in the Journal of Foot and Ankle Research found that older adults with less than 30 degrees of dorsiflexion at the ankle had measurably worse knee pain scores than those with full dorsiflexion, even controlling for arthritis severity. The test for this is simple. Stand a few inches from a wall, with the front foot a measured distance from the wall, and try to push your knee forward to touch the wall without the heel coming off the floor. If you cannot get close to the wall, the ankle is restricted. The fix is the daily wall ankle mobilization. Place the front foot 4 or 5 inches from the wall. Gently push the knee toward the wall until you feel the calf stretch deeply. Hold for 30 seconds. Repeat 10 times per side. Twice a day for 6 weeks usually opens the ankle up enough to take the burden off the knee. Cause number 5, and this is the one most patients have never heard of, is fascial dehydration. The fascia is the connective tissue that wraps every muscle and joint in the body. It is meant to be supple and slippery. With age, with inactivity, with chronic dehydration, the fascia stiffens and adheres, especially around the long IT band on the outside of the thigh and around the lower leg compartments. Stiff fascia restricts how the muscles glide past each other, which forces the knee to take load that should be distributed up and down the chain. This is the picture that the block therapy and similar fascial decompression communities have been pointing at for years. And there is a growing body of research, including a 2020 review in the Journal of Bodywork and Movement Therapies, supporting the role of fascial restriction in chronic regional pain. The research is still evolving. The clinical pattern observed in the literature was consistent. The simplest first step here is daily walking with attention to your stride, paired with adequate hydration. 2 liters of water a day, spread across the day, is a reasonable target for most adults over 60 who are not on fluid restriction for a medical reason. Talk to your physical therapist or physician about hydration targets if you have heart, kidney, or other conditions that affect fluid balance. Add to that a gentle foam roll or massage ball routine on the outside of the thigh and the calf, 2 minutes per side, 3 times a week. The fascia responds slowly. Give it 2 months before you judge the effect. Let me pause again. 5 causes: gluteus medius, hip flexors, VMO, ankle stiffness, fascia. None of them is arthritis. All of them, in combination, account for what I would estimate is the majority of knee pain in the cases I have reviewed in adults over 60. The arthritis was there in many of them, often as a quiet background finding. The arthritis was not what was hurting. The other 5 were. 2 composite patients before we close. The first composite case is documented as Genevieve, 68, a retired bookkeeper who had been told her knee was arthritis and would need to be managed forever. Her gluteus medius was tested and found profoundly weak. Her ankle was tested and found stiff. 12 weeks of side-lying leg lifts and wall ankle mobilizations, and her pain dropped from a 7 to a 1. She did not have arthritis pain. She had hip and ankle pain referred to the knee. The second composite case is documented as Lawrence, 72, a retired engineer who had been on the orthopedic surgery waiting list for a knee replacement. The documented protocol worked on his VMO and his hip flexors for 16 weeks. He came off the waiting list. That was 3 years ago. He has not gone back on. Here is the question to bring to your next physical therapist or physician appointment. Tell them, I would like to be assessed for the 5 non-arthritis causes of knee pain, in addition to the arthritis assessment. Specifically, I want to know about my gluteus medius strength, my hip flexor length, my VMO development, my ankle dorsiflexion range, and any fascial restriction. That is a substantive 20-minute assessment that a good clinician will welcome. Bring this protocol with you. Talk to your physical therapist or physician. If you do nothing else from this video, do the side-lying leg lift tomorrow. 10 on each side. Tell me in the comments which of the 5 causes you suspect is the dominant one for your knee. I read every single comment, and the patterns I learn from your replies inform what I teach in the next video. One more thing before I let you go. The frame I want you to take from this video is not that arthritis is a myth, or that surgery is never the answer, or that all knee pain is mechanical. The frame is that the conversation about knee pain has been too narrow for too long. Arthritis has been the default explanation for a complaint that, in many adults over 60, is being driven by something much more responsive to training. The good news in that frame is that you have real leverage. The 5 causes I have described all respond to consistent daily work, and the work is small, repeatable, and free. The harder news is that the responsibility now sits with you to do the work. 12 weeks of side-lying leg lifts, hip flexor stretches, terminal knee extensions, and ankle mobilizations is not glamorous. It is just consistent. The patients in the cases I have reviewed who recovered were not the ones with the worst arthritis or the best arthritis. They were the ones who did the homework, every single time. That is all for today. Talk soon. And remember, almost no knee invents its own pain. The knee is in the middle of the chain. Find what is happening above and below, and the knee almost always quiets down. Take care of your knees. Take care of the people who love you. Until next time, move well, stay strong, look upstream and downstream of the joint that hurts, and remember that the most important treatment for 60-plus knee pain is rarely a pill, rarely a procedure, and almost always a movement you can begin tomorrow morning at home. Pick the one that landed hardest while you were watching. Give it 12 weeks of honest, consistent practice, and the knee that has been hurting you for years often turns out to be a knee that was simply waiting for the rest of the leg to wake up and do its share of the work.